Okay, chapter 13, cardiovascular disorders. So we're going into the heart this time. Again, the disclosure, I don't own this material under fair use. I'm providing lecture content for only my nursing students using this material. All content within is for educational purposes for nursing students and not for medical advice. All right, so for this chapter, chapter 13 in your book, our goal in our learning outcomes is to identify the normal assessment of anatomy and physiology of the pediatric cardiovascular system, the pediatric physical assessment components, the anatomical features, clinical presentation, stabilization, emergent and long-term care of a child with cardiovascular disease. Identify nursing interventions necessary to educate the caregiver of the child, common diagnostic tests being used, and then develop a nursing care plan for a child with a cardiac condition. So what does that look like? In your book, you're going to have to go back to 101 in the anatomy and physiology of the heart. You have to know where things are to understand the flow of the blood through the heart, and then what is wrong. Okay, so the vena cava carries blood to the right atrium. The superior vena cava lies above the heart and carries blood from the head, arms, and upper body. The chambers of the heart, you need to know where the chambers are, where systolic and diastolic blood pressure comes from, the valves of the heart, the vessels of the heart, because there is such a thing in children with the transposition of the aorta. So you have to know these things. You have to know what is open, what is not flowing, and where is it going for most of the things with the baby. The baby is not like an adult. So in cardiovascular, like at Johns Hopkins, when you go to Johns Hopkins, you are always going to go back to the CVICU if you have a congenital heart defect. You cannot go to an adult doctor because your problem is congenital. It's not old age related. So as long as you live, you will have to go back to Johns Hopkins because a normal heart doctor will not see you. They're not used to the congenital side of heart defects. That's what a pediatric heart specialist is for. Okay, so you've got to know your valves, your vessels, the normal blood flow, cardiac output, stroke volume, pressure gradients, the electrical conduction, and the fetal circulation. So you've got to know how it was going during utero and how it's going now and what changes are. So NRP, the neonatal resuscitation program, has great pictures of that. If you search that online, there will be tons of pictures. So you've got to know how was blood flowing prior to the baby taking its first breath. So you're going to have to know the normal blood flow. Your cardiac output, your stroke volume, you're going to need to know that for this test. Cardiac output is calculated by multiplying stroke volume by heart rate, and it's measured in liters per minute. You got to know that. So electrical conduction, you need to know, like, where is the P wave, where's the Q wave, where's the R wave, what does it mean when these are wrong? So in fetal circulation before birth, 90% of the blood bypasses the lungs. The placenta is the organ of respiration. Oxygenated blood is returned via the umbilical vein to the right atrium in the inferior vena cava. So deoxygenated blood will flow from the superior vena cava to the right atrium and then to the right ventricle, the pulmonary artery, the patent ductus arteriosus, and the aorta. Upon birth and that first breath, the foramen orale and the ductus arteriosus close, or are supposed to. Therein lies the problem. So you've got to know PDA. PDA is one of those things. PFO is one of those things you've got to know, because a patent foramen orale will cause problems, and a patent ductus arteriosus causes problems. The PDA, we give indomethacin, ibuprofen, or Tylenol to get them to close. Ibuprofen was only 50% successful in closing those. That's why we now use more indomethacin than anything. But we can still use Tylenol. If that doesn't close, we're going to go in and physically close it with sutures to close that hole in the heart. This is the reason why you tell moms not to take ibuprofen during pregnancy. They can take anything Tylenol for pain and sleep, but they cannot take ibuprofen because that makes the PDA close early. So congenital birth defects are a little different than old age defects. So congenital is either congenital or acquired, are both heart defects that are genetic. So congenital are genetic, meaning the child is born with the disorder. These defects affect 6 to 8 in 1,000 live births. So it's not something you see every day, but it's frequent enough. Defects can either be from a single lesion or multiple abnormalities. So cyanosis occurs when the blood flow in the lung is insufficient and there's a lack of blood. A large portion of deoxygenated blood is pumped into the systemic circulation when the hemoglobin is less than 5. So cyanosis gives you a good clue that the child's oxygen saturation is already less than 85%. So when you see circummolar cyanosis of the child, you already know they're at less than 85%. All right, so there's classifications of congenital and acquired heart disease. You're going to need to know these things because they're going to give you a case and you have to decide what it is. So PDA, atrial septal defects means that the wall between the atria is open. The septum didn't form correctly. So the blood that's deoxygenated and reoxygenated are mixing. Ventricle septal defects is the ventricle wall is got a hole in it. So both of these we can go in and sew it shut. That's what the child will have. They do it quite frequently at Johns Hopkins. So it's a child hospital thing. Decreased pulmonary blood flow. So tetralogy of Fallot. Tetralogy of Fallot, I just say it as tetralogy of flow, and that helps me remember what's going on. So the blood is going backwards in the heart, so the flow of blood is not working well, so it backflows into the heart. Tricuspid atresia, so the tricuspid valve is open. Okay. Obstructive disorders, coarctation of the aorta. Make sure you understand coarctation of the aorta. Aortic stenosis, so stenosis meaning closure, so it's closed more than it's open. There's stenosis in the aorta. Pulmonary stenosis or pulmonary atresia, and then we can always have a tetralogy of flow with pulmonary atresia. So these kids turn blue. There's mixed disorders as well. So the biggest one there under that classification is transposition of the great vessels. So the vessels have been switched at birth to the right and the left side rather than the left and the right side. So it's literally the great vessels have turned in the heart. They can work that way. It's just they're backwards. Truncus arteriosus, hypoplastic left heart. Just think about that. Hypoplastic, it's not as flexible. Hypoplastic. Okay. And then the genetic disorders of cardiac malformations you can see in the chart in your book as well. So the myocardial conduction pathways will be different. Acquired heart disease means that normal heart or the heart with a congenital defect can occur with acquired disease. So infections, autoimmune disorders, genetic factors, teratogens, so any inhaled, ingested, absorbed agent, chemical agents, alcohol, angiotensin receptors, chemotherapeutic agents, smoking, isoretinoin, lithium, calcium, cocaine, warfarin, dilantin, vitamin A, and others. So this is the reason why we tell moms they need to tell us if they are pregnant, because we need to take them off those medications. Remember what I said, retina A, they've got to have a second form of birth control? It's because these are the congenital anomalies that can happen when things are occurring. So a cocaine, a lithium, a smoker, chemotherapeutic agent, an ACE inhibitor, alcohol, things like that, they're looking for the heart defect. The other thing would be like Down syndrome. It's well known that Down syndrome has the more probability of having a heart defect. So we'll do a heart scan for that child if they're having trouble. Infectious agents. So here's your cytomegalovirus, rubella, varicella, HIV, toxoplasmosis, herpes, varicella. These are your live vaccines. This is why it causes heart defects. That's why you don't want to give those live vaccines. So it's all coming back. Maternal factors such as infant of a diabetic mom. It increases the risk of neural tube defects, malnutrition, and thyroid disorders. And physical agents like hyperthermia, that's a teratogen. So if a mom goes into a sauna or a hot tub and an infection increases her body temperature, this can result in central nervous disorder or abdominal wall defects. So these are the reason why we tell patients not to do certain things while they're pregnant. This is where it all comes back. Okay. So you can see the fetal circulation in there. So you understand better now. When they drink, they pee, they pee, they drink, and everything's going through the placenta. The placenta literally is the I-4 of the baby. It's doing all the work for the baby. So that ductus arteriosus. Okay. So you're able to see that in your book in figure 13.7. So there is a great chart, 13-1, for that cardiac defects, and it tells you in the class of the drug whether it's a cyanotic defect, an obstructive defect, or a left to right shunting. Left is lungs, right is body. So there's a left to right shunt in those atrial septal defects, the VSD, the PDA, AV canal. Okay, you can see the prevalence of this. It's not common, but it's the most common abnormality that could happen. And it could be incompatible with life. A lot of these are not emergent, run to surgery, but more get them stable, then take them to surgery as quickly as possible. So obstructive lesions, that stenosis, okay, versus your cyanotic. Your cyanotic, more troublesome. If they're being cyanotic, we got to worry that the spleen, the liver, the kidneys, everything is affected with that. So your cyanotic defects, the big ones that I would look at is your tetralogy of Fallot. They love that. A tricuspid atresia, truncus arteriosus, a single ventricle, that could be a big problem. Okay. So that chart will be very helpful for you. And then syndromes associated with cardiac disease. So again, any of these would be an association with a cardiac issue. So your Down syndrome, muscular dystrophy, muscular because the heart's a muscle wasting is going to be one of those issues. Marfan syndrome, trisomy 18, 13, fetal alcohol syndrome. There you go. Fetal alcohol syndrome, Turner syndrome. Again, Turner syndrome was on the last test. It could pop back up. So kidney problems, high blood pressure, lack of sexual development, webbed neck, low hairline, drooping eyelids, low set ears, abnormal bone development, multiple moles, things like that with Turner syndrome. If you have suspect of these things, then we're going to go ahead and watch that baby a lot closer. And then we're going to end up having the ultrasound tech come and do an echo. All right. So then physical exam. Let me just see where my slides are going on this. So chest pain is a common, rare, permanent, or imagined symptom in the pediatric client. It's going to be a rare one. Chest pain is not going to be the problem. A child is respiratory driven. Always remember that. All right, so we talked through some of these disorders. And then additional disorders to think about, like hyperlipidemia, hypertension, rheumatic heart disease, subacute bacterial endocarditis could also be occurring, and that would be a more acquired problem. Okay. Hyperlipidemia through diet, through congenital uh, genetics, hypertension could also mean kidney issues as well. The rheumatic heart disease is going to come from your strep throat. Kawasaki's disease, that comes back in to play, and heart transplantation. Okay, so we're going to stop right there on the slides. In your book, I'm still on page 259. 259, remember the biggest thing with heart disease, the possible indicators for heart disease when you're seeing a child is failure to thrive, small for gestational age, poor weight gain, abnormally formed features. Infants with congenital heart defects are usually more typical to have developmental disabilities too. Chest wall deformity, scoliosis is more common in adolescents with congenital heart disease. Clubbing of the fingers and toes. So you remember clubbing from A and P. Clubbing is going to occur with long-standing cyanosis, enlargement of capillaries, excessive growth of soft tissues in the fingers and the toes, and it's a result of chronic hypoxia. Hypoxia, heart disease, not necessarily cystic fibrosis, okay, because they love to trick you with that. Clubbed fingers is a lack of hypoxia of oxygen. Polycythemia is an increase in the red blood cell mass, increases blood viscosity, and the ability of the body to eliminate, to actually perfuse those tissues. Polycythemia predisposes the child to stroke and clot formation. So consider polycythemia one of those things that is indicative of hypoxia. You're going to have blood that's viscous. You're going to have blood that's not able to perfuse. Okay. And then with the respiratory system, you're doing a really good assessment on respiratory rate, retractions. Again, remember, retractions, grunting, and flaring tell you that there's a problem with hypoxia. Shallow, rapid respirations, more than 60 a minute, are abnormal and need to be investigated because it indicates left to right shunting of blood in the heart. So again, if the child is breathing more than 60 a minute, you're not feeding them because they cannot suck, swallow, and breathe at the same time. That would literally be a suck and a swallow every heartbeat, every minute. You can't do that. Congenital heart disease, they usually have respiratory tract infections, dyspnea with activity and fatigue, and you want to closely observe that infant for respiratory distress and cyanosis during feedings. So these kids will turn blue during a feeding, and that indicates to you that the body's just not ready to deliver oxygen. So those kind of things we'll talk about in a little bit. Respiratory symptoms indicate pulmonary edema, which increases the work of breathing with grunting, flaring, and retractions. Grunting, flaring, and retractions, the kid needs to go to the back. Cardiovascular wise for assessment techniques, you know from your head to toe assessment class that it's inspection, palpation, percussion, and auscultation. So you're still going to do that level of alertness check, the activity, their tone, chest symmetry, any pulsations, capillary refill, pressing on the sternum or the forehead. Normal is equal to or less than 3 seconds, so your cap refill time. And then poor circulatory output or perfusion is longer than 3 seconds. So you're looking for that 3-second refill. Again, cardiac-wise, you're looking for your 5 main heart sounds. You know, all people eat tasty meat or all people enjoy Time magazine. Remember that, refresh that, where you find those heartbeats. And then when you're doing their pulses, you're looking for pulse volume. Remember, 0 is absent, weak is 1, average is 2, strong is 3, and bounding is 4. When it's normal, it's pretty easy to feel in a child. Remember back to CPR that we usually don't use the neck. We usually use the upper arm for the brachial. And that average rate is 160 per minute for an infant, 120 for preschool child, and 100 for adolescents. Remember to include all of your pulses for pulse deficit, so radial, carotid, brachial, and femoral. They should be equal in strength between the right and the left. Bounding pulses in the upper extremities and decreased in the lower extremities tells us that there's a coarctation of the aorta. Pulses that are bounding might also suggest systemic hypertension or PDA. So if they're bounding pulses, we're kind of weary what's going on there. Cardiac pulsations are seen in the subaortic stenosis. So we shouldn't see those pulsations. If it is, we need to report it. Peripheral pulses give you an indicator of cardiac output, systolic and diastolic pressure. Bounding pulses indicate excessive volume, fluid volume. Why would there be excessive fluid volume? The kid is blowing up in front of you. retention of fluid. Pedal pulses on top of the foot and medial malleolus can be felt on a baby. Peripheral edema, there you go. There's your water. Thrills, bruise, all that good stuff. Temperature, feel the child. More times than not, your child's going to be a little blue with the acrocyanosis, but they should have figured it out by at least 8 hours of birth. But acrocyanosis can deal up to 24 hours. And then most people, their jaw drops when they see the blood pressures of kids. For us, the bigger thing is that we look at the map. We don't necessarily look as much with the numbers. So we don't freak out when we see like 50. It's no big deal, right? But you have to think about that. So gestational age, weight, postnatal age is going to change things. Also using the prepper size cuff is still important. So in newborns, mean arterial pressure is usually the millimeters of mercury and is usually the newborn's completed week of gestation. So BPs are not a routine part of a neonatal assessment on a newborn, but we do blood pressures to check for a pulse deficit. We also look for the presence of a murmur that way as well. So we'll do 4-point blood pressures before discharge. That tells us if there's a murmur or a heart defect. So BP taken in either the left or right leg, arm. Blood pressures measure from 50 to 75 systolic and 30 to 45 diastolic, which freaks people out. And then in older children, you just use the minimum systolic is 70 plus 2 times their age and years. So forelimb extremity BPs are indicated if cardiac disease is suspected or a murmur is present. We do them on all babies before they go home, just to check. And then you'll see the doctor feeling on the baby's belly. That's because of hepatomegaly. We want to make sure that we don't have a hepatic liver going on. That is highly suggestive of congestive heart failure if we have a huge liver on a baby. So then when you're looking at the child, you're also looking at the color. So cyanosis is blueness. Central cyanosis is blueness in the mucous membranes, tongue, circumoral, or body core. Peripheral cyanosis, not worrisome in the first 24, 48 hours of life, but a pulse ox reading of 78 or lower would certainly be concerning. We're always looking for skin that's pale, mottled, or gray, and the urine output is a huge indication. Remember, a cc an hour for most babies per kilogram. So your mottled skin is telling you the child is not doing well. Mottled is kind of like at the end of life when you get mottled. It's like a lace-like appearance. And then when you're auscultating again, you're doing your 4 main spots, looking for lub-dubs, gallops, and the point of maximum impulse is still going to be there. So you're not going to really listen for an herbs point in kids. So you're doing your 4 signs instead of the herbs point that we usually do in adults. It's too close together to be able to discern that. So murmurs come and go with kids, so we're not really concerned unless it's a really, really loud one that won't go away. Murmurs come and go with the opening and closing of flaps. So we'll send the child for a chest x-ray, AP and lateral. Blood gases could be done as well with the baby. And then echocardiogram. So typically the EKG guy will come, echocardiogram, an ultrasound of the heart will be done. And then just remember, like a cardiac cath in an adult, the same thing every time. Every time you hear cardiac cath on the test, it's going to be about bleeding, right? Think about preparation on the developmental age and the parental involvement, just preparing them for what's going to go on. A sedative is administered. A local anesthetic will be administered in the femoral vein. Cardiac cath is done with contrast dye. So you're talking about INO, allergies. Keep the extremities straight for 4 to 6 hours with no movement. How are you going to do that with a child? They don't understand. So they need to be positioned flat on their back, a sandbag. They could have restraints. A Foley catheter might be used. We don't really want them peeing around that site. Check pulses above and below the catheter site. You're looking for occlusion. You're looking for bleeding. Pressure dressing for 24 hours. Auscultate a normal heart rate. If you feel abnormal heart rates or rhythms, they need to be checked right away. Looking for temperature changes, color changes in the arm or the leg that's used for catheterization. No tub bath, showers are okay. Avoid strenuous exercise. Attending school is appropriate after 72 hours. And then notify the physician right away if there's any infection, obviously. Regular diet, return to school within 3 days, and a follow-up appointment. So lots of caregiver education on here. Caregivers need to know that follow-up with a cardiologist is for the rest of the child's life, forever. And then again, endocarditis prevention is necessary for some children before they have dental or medical procedures. So again, bacterial endocarditis. Prosthetic valve repair. Prosthetic valve repair and strep throat, rheumatic heart are the only two that you give antibiotics before dental procedures. So then they start going into each one of the congenital defects. Again, I'm going to leave that out there for you. So PDA, that little flap of skin being open. And it's more so associated with premature babies because it's not time for that to close yet. So assessment of a PDA would be a wet sounding breath sound, poor feeding, poor weight gain, using endomethacin, ibuprofen, could be digoxin as well. And again, the hold rate for that would be 90 in a child, 70 in a child, 90 in a baby. Okay. And then surgical management, they would just go in and ligate that duct, close that duct. Atrial septal defect, again, the septum is a problem. So shortness of breath, tires easily when playing, poor feeding. Poor feeding seems to be a trend here. You can't eat and drink at the same time when you're trying to hold your pulse rate up. Ventricle septal defect. So new and old blood are being mixed. The tetralogy of Fallot, this one especially, they love to use because it's all four opening. So you can imagine that the new and the old blood is constantly mixing. This is the kid that would go to surgery fastest. So this kid is right to left shunting. They have TET spells. Whenever you hear TET spell, you want to decrease their height, which means pulling their legs up on their chest or telling them to squat down. That helps with the flow. So hypoxic brain injury and death from these TET spells. So a pink TET spell is caused by left to right shunting. Increased cyanosis with irritability when they cry. Increased irritability because of the lack of oxygen. Irritability, lack of oxygen. Clubbing of fingers, poor growth, chronic lack of oxygen. So during those TET spells, you teach the child or you help the baby pull their legs up to their chest, or they squat during a TET spell, and that increases the blood flow back from the legs to the brain and the vital organs, increasing systemic vascular resistance. You fold them in half. Okay. Again, these kids are going to have polycythemia. Okay. Tricuspid atresia. So this is a heart condition where the tricuspid valve is either defective or missing. Prostaglandins are given. So prostaglandin is a vasodilator. So it keeps the foramen orale and the ductus arterius open for us. So again, this kid is going to have a murmur, clubbing of the fingertips, delayed growth, poor weight gain, shortness of breath, cyanosis. So you're going to prepare this kid for surgery. Prepare the family for a series of corrective surgeries. And you need to maintain the prostaglandin administration to maintain the blood flow. And then a balloon septoplasty could be performed. Again, several surgeries, lifelong cardiac care. Other surgeries could be required. Eventually, this child would be transitioned to an adult cardiologist, but some of them will not take them because they're not familiar with cardiac congenital anomalies. Okay, coarctation of the aorta. Coarctation means a heart defect that narrows the aorta. So in that narrowing, can happen preductally, ductally, or postductally, and it increases the blood pressure in the upper extremities, head, and reduction of blood pressure in the lower extremities. So this is more commonly with Turner syndrome. If your pulses are not adding up, we got a problem. CHF, so you're looking for those kids that are blowing up. Again, assessment of pulses is huge. Aortic stenosis, so you see the aortic with a little closure there. shortness of breath, murmur, narrow pulse pressure, exercise intolerance. That leads to sudden death. That's a problem. So sometimes these are the kids out on the football field or the soccer field. And the scarring of the aortic valve can also occur with rheumatic fever. So here's your rheumatic fever, strep A, pneumatic fever from strep throat. Here you go, aortic stenosis. So you're looking for symptoms of congestive heart failure, atrial fib, home care instructions, pain control, prostaglandin drip, and then providing bacterial endocarditis information like getting antibiotics before going to a dental procedure. So stenosis, pulmonary issues have more to do with hepatomegaly. So this could be seen in Noonan syndrome or tetralogy of Fallot, murmur, shortness of breath, cyanosis. Again, echocardiogram, cardiac cath, balloon angioplasty, frequent follow-up visits. Okay. So it just keeps going. So that transposition of the great vessels is on 272. And that transposition of the great vessels you can see in the picture. The two great vessels, the aorta and the pulmonary artery, are reversed. So non-oxygenated blood is flowing to the brain. That causes brain damage. Two separate circulatory systems that don't mix. Pulmonary artery receives oxygenated blood from the left ventricle. The survival of this child requires a mixing of oxygenated and unoxygenated blood at the ductus arteriosus. So with these kids, these guys have to go to Johns Hopkins right away. This is a cardiac emergency. Within the first 24 hours of life. So this child decreased O2 sat, upper from lower extremities. Their O2 sats are not working the same. So this is the reason why we do the pulse oxes before discharge at 24 hours old. The infant presents with profound cyanosis, crying, tachypnea, heart murmur, and CHF signs and symptoms. So they're holding fluid. So cardiac cath. Our goal is to keep O2 sats greater than 75% to keep that sustained pulmonary vascular resistance. So they might have captopril or enalapril to relax the coronary arteries. And then after arterial switch procedure or a balloon procedure, they are also going to see the cardiologist, but also the neurologist because of the brain being affected. Truncus arteriosus is when the single great artery from both ventricles has an overriding VSD. This is German measles, DeGeorge syndrome, Down syndrome, diabetic moms, infants with excessive alcohol consumption. So there's a mix of oxygenated and deoxygenated blood, which means cyanosis. Diaphoresis, wheezing, grunting, retractions, wide pulse pressures, difficulty in feeding, pulmonary congestion, loud murmur, loud murmur. Okay. Let's see what else we got on our slideshow. So cardiac dysrhythmias, the dysrhythmias that you're going to see in kids, hold on, let's go back up here. One slide here. Hold on. Let's go back up here. We talked about hyperlipidemia, rheumatic heart, especially due to your strep A. That's in your book as well. And then subacute bacterial endocarditis, vague symptoms, low-grade fever, high-grade fever, fatigue, cough, heart murmur, chills, shortness of breath, joint pain, petechiae. All of these things are going to win you blood cultures. Check it out. Roth spots are round or oval white spots sometimes seen in the retina in early stages. Janeway lesion is a flat, painless, reddish, bluish red spot on the palms or the soles of the feet. Splinter hemorrhages. They love to ask this. Bacterial endocarditis and splinter hemorrhages. Look at your nails. If there's a splinter hemorrhage, it's a black or brown line underneath the nails. Splinter hemorrhages, they're always talking about bacterial endocarditis. Just to let you know, that comes up frequently on the NCLEX and tests. Again, if not treated, it can lead to the bacteria or the fungi breaking off and traveling to the brains, lung, kidneys, other organs, causing a stroke. Poor breathing, poor weight gain, edema, valve failures, septic emboli. So again, transplantation of the valves. It's a valve issue. And then again, maintain good dental hygiene, prophylactic antibiotics with these kids. So dental procedures for children with heart disease, a prosthetic heart valve, endocarditis, a heart transplant, certain congenital heart defects, congenital heart disease. These children are going to end up going for prophylactic antibiotics because they're the most at risk. Kawasaki's disease, you know your Kawasaki's. Just make your motorcycle, right? So your motorcycle, it's going to affect the heart. Signs and symptoms last longer than 5 days, include a fever, and 4 of the symptoms conjunctivitis without exudate, painful joints, red lips, strawberry tongue, congested oral pharynx, lymph nodes, groin rash, edematous red hands and feet, scarlet fever rash, WBC's up, extreme irritability, cardiac involvement. There's your symptoms. If I were a betting woman, I would probably think that would be on the test as a fill in the blank. So again, our issues with this one is maintain anti-inflammatory, high dose salicylic, that's aspirin, which can also be continued for 6 to 8 weeks as an antiplatelet therapy. IV gamma-globulin is given for the first 10 days to prevent coronary aneurysms, monitor the child's cardiac status, and symptom relief. It's usually self-limiting, but remember those meds. And then heart transplantation, the goal there is, well, we don't have another organ, right? So it's transplant rejection. So again, they do these at Johns Hopkins frequently. There's an organ team that helps you. So transplant rejection would sound like clinical judgment, the box on 283. Clinical judgment, these are symptoms that you would be looking for someone who is rejecting their organ. Fever, decreased output, decreased wet diapers, elevated heart rate, fast breathing, weight gain, fatigue, irritability, poor appetite, palpitations, anxiety, lightheadedness. Okay. All right. So tachycardia, too high heart rate, a heart rate greater than 220 would be supraventricular tachycardia. You stimulate the vagal response through nasal suctioning. Apply ice to the forehead. Adenosine can be given. Or older children, we can ask them to bear down when like having a bowel movement, and that would stimulate the vagus nerve to slow the heart rate. So depending on the question, depending on the age of the child, so anytime it's over 220, ask them to bear down if they're old enough to understand that. So ventricular tachycardia would be ventricles, loss of consciousness, and sudden death. So that's not good. Torsades de pointes is your QT interval. That's always a magnesium issue. When your magnesium gets too high, you end up in torsades de pointes. It's sudden, unexpected, life-threatening ventricular tachycardia. Could be with diarrhea, malnutrition, hypomagnesia, hypokalemia, hypocalcemia, or some antiarrhythmics. A rapid decline in the BP, so they faint, ventricular fib, and dead. Bradycardia, I would rather have bradycardia than tachycardia. Bradycardia is an AV node, sinus brady, when the QRS follows the P. That kind of looks like heart block. A pacemaker might be needed. And then your Wolff-Parkinson-White syndrome is electrical stimulation, reaches the ventricles too soon, tachycardia, syncope, chest palpitations, death. We could do ablation therapy. Okay. So shock in kids, just imagine that we have less blood flow and oxygen supply, and kids have less volume. So it's the leading cause of childhood morbidity and mortality. It's often very difficult to diagnose. And they have hypovolemic, which means profound dehydration, cardiogenic, damage to the heart muscle, resulting in pump failure, and septic or distributive, so blood vessel dilation, sepsis. Shock can affect any of the end organs. It's a medical emergency. So depending on the cause, your treatment's going to be fluids, blood products, antibiotics, and then stuff to increase the BP and delivery of oxygen to the heart. Again, BP, chest x-ray, echocardiogram, arterial blood gases. Your issue is to maintain medications, IV access, and fluids at all costs, and oxygen. This one, you would provide education to the parents after the emergency on the DASH diet, rich in fruits and vegetables, lower the blood pressure, total cholesterol, and LDL. Remember your DASH diet. It's always a good test question. All right, here's a checker for us. Leading cause of acquired heart disease in children. Acquired Kawasaki's. Acquired, right? So not genetic. They only acquired disease. Again, we have covered the anatomy and physiology, the assessment, the congenital flow of blood, pre and post delivery, congenital heart disease, additional disorders, cardiac dysrhythmias, and shock in this chapter.